way as men who may never have initiated pregnancy. So the evaluation of the infertile male should be performed by a urologist, typically a reproductive urologist, and include a complete reproductive and medical history, physical examination, and at least 2 semen analysis, because semen analysis can vary considerably. The reproductive and medical history should include looking at the frequency and timing of the intercourse, the duration of the infertility, prior fertility, a review of childhood illnesses and developmental history, any medications, any systemic medical illnesses, diabetes, upper respiratory diseases, let's say recent COVID exposure or other infections, and prior surgery, such as hernia repair or other testicular surgery, as well as an evaluation of the sexual history, including any history of sexually transmitted infections or exposures to toxins like heat exposure, chemical exposure, radiation, and including smoking, drug use. And then in addition, the family reproductive history is also very important because oftentimes it can be passed on from one generation to another. A general physical exam is really an essential part of the evaluation. And in addition to sort of the head to toe evaluation, particular attention is made to the genital area, looking at the penis, making sure that the opening of the urethral meatus is normal in terms of size and location, looking for any plaques or lesion to ensure there's no curvature or corones, and then a careful assessment of the testicles to look at the general size, the shape, consistency, and then looking at the ductal structures, looking at the vas deferens, which allow the transport of sperm, the epididymis, which is important for the maturation and processing and storage of sperm, and then looking for enlarged veins in the scrotum, what we call varicoceles, which are very similar in terms of the varicose veins that a lot of men and women have in their legs. And then looking at secondary sex characteristics, looking at the body shape, distribution of hair, whether or not there's any enlargement of breast tissue, and where appropriate, a prostate exam or rectal exam. So based on the results of this evaluation, urologists often will recommend other tests and or procedures to determine the cause of a patient's infertility. And these additional tests may include additional semen analysis, hormonal evaluation, ultrasound, such as doing an ultrasound of the scrotum to evaluate the testicles and the surrounding structures. Where appropriate, sometimes we'll do an ultrasound of the prostate and the seminal vesicles to look to see if there's any blockages or swelling or cysts that might suggest potentially correctable factor. And then certain specialized tests, DNA tests, and other genetic screening. So that's just a brief overview of male infertility approach. So I think I'd like to stop there and then move to your important questions here. So just bear with me here as I pivot. Okay, so the first question that I see here is, if your male partner is unable to have sex as frequently to help increase chances during ovulation, is an at-home insemination a good alternative? And how successful is that generally? So, good question. There are FDA-approved home insemination kits that are available. And there is a role for them with respect to couples or individuals who may have some anatomical challenges. For instance, if the female partner has pelvic floor dysfunction or vaginismus and has pain with intercourse, and or if their partner might have erectile dysfunction or premature ejaculation, it gives couples the option to do so at home. I think it's important, however, to make the distinction. To my understanding, these home insemination kits allow for intravaginal insemination of semen, meaning placing the semen into the vagina, which may be effective and is effective. However, generally, a healthcare professional is really the one to perform intrauterine insemination, where the semen is not just placed intravaginally, but into the uterus. So there's a higher rate of success with that and other techniques that optimize successful results. And there may be other couples who use it for donor insemination. So the kits allow for that as well. So I think it's something that's relatively new, and I think best discussed with the reproductive gynecologist or REI that you're working with. So the next question here is, with very low sperm count and male factor infertility, is it suggested to obtain from ejaculation before the day of the retrieval, or is it suggested to refrain from sexual activity for at least 2 days before the retrieval to get a better sample? And it kind of depends, because the general method for most sperm or semen production has been wait at least 2 days to optimize the volume of the ejaculate and the sperm concentration and motility, because oftentimes if there's an ejaculation in a shorter period of time, you see a lower volume. The pendulum has swung a little bit more lately. There's increasing data to indicate that for certain men and couples, in order to procure higher quality sperm for IVF, it may be worthwhile to actually ejaculate within 24 hours of producing a sample for IVF, especially for severe male factor. There was an article that was written by Dr. Peter Schlegel at Cornell, and he and his group have been doing that with the rationale that you're getting sort of a fresher sperm that is packaged through the epididymis. So I think it depends on the circumstances for the couple. So the next question is, what do you recommend if a partner has a higher than normal percentage of sperm defects? So it's actually relatively common as a reproductive urologist to see men in the clinic who have a low percentage of normal morphology, what we call teratospermia. So the criteria for what makes a normally shaped sperm has become stricter and stricter. The labs now use Kruger morphology to really determine what's a normally shaped sperm, because a lot of the sperm, the majority, are abnormally shaped. They may have head defects, they may have neck defects, they may have tail defects, a combination of things. But it doesn't correlate per se with the quality of the DNA within the sperm. So there's no clear correlation between the shape of the sperm and abnormal DNA within the sperm. So there's sort of two schools of thought. One school of thought is that the morphology, even if low, may not really make much of a difference. There's some studies that indicate that really assisted reproduction or IVF is the way to go when the morphology is very low, let's say between 0 to 1%. But for others, IUI, intrauterine insemination, or natural attempt is certainly reasonable. And again, many of these couples have been trying naturally for at least 6 months, if not a year. With that said, the guidelines still recommend generally that males with a lower percentage of normally shaped sperm should still be seen by a reproductive urologist to ensure that there may be not other contributing factors to subfertility. Let's say, for instance, enlarged veins or growths or cysts or hormonal imbalance, which are remarkably common findings. And these other factors may be playing a role, excluding, let's say, things like sexual dysfunction or ejaculatory disorders. So the next question here is, do you see unexplained male fertility improve often? I can honestly say it's a bit mixed. So, when it's unexplained male fertility, that suggests that we've done everything we could together to really identify and potentially correct a male factor. So assuming a full evaluation has occurred, we're at a point where we just don't know why the semen parameters are diminished. Now, at least 50% of men that we see in a male fertility clinic have an identifiable and correctable male factor. As I mentioned, commonly we find hormonal imbalances. There have been studies indicating that at least 40% of men presenting in a male fertility clinic may have low testosterone. Very high number of men also have these enlarged veins in the scrotum. And then oftentimes men are taking medications or supplements that may be kind of mixed. Some of them may contain testosterone variants that might be affecting fertility, or other things that we're just not aware of in the environment, chemicals, exposure, things like that. So it's a tough thing to answer. Fortunately, even for unexplained male infertility, we do have assisted reproductive techniques to really allow couples to have a successful pregnancy through intrauterine insemination, IVF, ICSI. So we're very fortunate that even though we don't understand some of the male fertility, and again, a lot of great work is being done to look at the etiology, we do have these successful technologies. And it's really been life-changing for many, many couples. Is there anything men can do to help improve their fertility? Yes, I think that, as I tell many of my patients, what's good for your health is good for your sperm, because we're one organism. So we always try to encourage a healthy diet and lifestyle, a healthy body weight, and exercise. This helps the mind and the body, and avoiding negative habits such as smoking and avoiding testosterone products, because regrettably about a third of men of reproductive age have been taking or are prescribed testosterone products without the understanding or full knowledge of the consequence of negative impact on sperm production. So the next question here is, can successful IVF occur with non-motile sperm? My partner had a microtessie, and a microtessie, for those who don't know, is a specialized procedure using a microscope where the testicles are explored and they're opened up, and the tissue and the tubules are looked at in detail, with the idea that the urologist is trying to extract tubules within the testicles that appear more plump and healthy and may contain some sperm. And we do, generally find sperm in those men about 50 to 60% of the time. Those are typically men who have what's called azoospermia or non-obstructive azoospermia, so they have a production issue or challenge. So if sperm is found, and the doctor tells the couple that they do not have fully motile sperm, can they still move forward with IVF? And is that treatment successful? And the answer is yes. In fact, the majority of sperm that are extracted successfully through microtessie are non-motile. And so we tend to think, well, if they're non-motile, they're dead. But that's not the case for the majority. And those sperm can be used for ICSI, where the sperm are injected into the egg, as I mentioned before. Now, there's increasing studies and techniques looking at trying to evaluate those sperm to really see which of those may have superior quality. Sometimes they use pentoxycycline to try to see if they can stimulate motility a little bit. But at the end of the day, yes, it can be used for ICSI. So next question is, how can ICSI, intracytoplasmic sperm injection, help with male infertility? And so we use ICSI commonly for severe male factor, meaning sperm counts that are very low, depending on your definition. That's usually less than 5 million, whereas the cutoff for normal is about 15 million or higher. If there's, issues with egg penetration, if there is what we call high sperm DNA fragmentation score, so we do sperm DNA tests, and if the scores are elevated, oftentimes it's recommended that couples move directly to ICSI and not go through intrauterine insemination or even standard IVF unnecessarily. So ICSI is a revolutionized treatment. It's improved the prognosis for infertile men with severely diminished sperm counts, severely diminished sperm motility and morphology, and as I mentioned before, azoospermia. All right, so the next question here is, can you please talk about the pros and cons of using fresh versus fresh, or frozen versus fresh sperm for IVF? For a male who is azoospermia and is freezing a few samples for use with IVF, assuming that's successful sperm extraction, freezing for IVF. So believe it or not, generally frozen sperm versus a fresh sperm is remarkably similar in terms of outcomes for IVF. The labs do a tremendous job with their fancy technology to freeze the sperm and to thaw it out in a very gentle and supportive fashion. There are situations, though, where we do decide to go directly with a fresh sperm extraction, which means that the partner's stimulated for egg extraction. At the same time, we coordinate that with the sperm retrieval and ensure that that's used together within a short period of time. There are situations, certain cases, where the males have very, very small testicles, and they may have a genetic condition such as Klinefelter's. So that's a common condition that we see in men who have azoospermia. They have small testicles, and they do have some sperm in their testicles, but it's usually a very, very small amount. And sometimes the shape of the sperm is a little less than ideal. So in that kind of situation, it's a small enough amount of sperm that's extracted about 50% of the time. And in that kind of situation, they don't do well in terms of freezing and then thawing, because there may be little, if any, sperm left if we did that. So in those situations, we will do a fresh TESE, and that works out well for couples. Other indications may be in couples who have had prior failed IVF attempts, usually at least 2 or more. And they look at the progression, and oftentimes if they don't, progress to the blastocyst phase, let's say day 5 or 6, then it's oftentimes considered a male factor, even as early as 3 or 4 days, I should mention. Then there's a high chance that there's a male factor, and in which case we may decide to do a fresh TESE. Next question here is, if sperm analysis shows 3 negative factors, such as low fluid or volume, low sperm count, and low motility, would you still recommend IUI or would you suggest IVF? So ultimately, for couples, it's primarily the reproductive gynecologist, or REI, who will really be making the recommendation with respect to IUI or IVF. As a general rule, for IUI, couples do need an adequate volume of semen and adequate sperm counts, usually about 10 million per mil, and reasonable motility. Because if the numbers really fall below that, then chances of IUI being successful are further reduced. Usually with IUI, you're looking at success rates of around 10%, as I understand, per attempt. So if you're having lower semen parameters than that, it really doesn't make a whole lot of sense, but it can be done. So for those couples, generally, we recommend IVF, especially if we've determined there isn't a correctable male factor, or there isn't other female factors that might preclude moving forward with IUI, such as, a tubal factor where there's blocked fallopian tubes or scarring and things like that. Certainly, for any gentleman with an abnormal semen analysis, he should see a reproductive urologist. And this is actually in keeping with the guidelines from the American Society of Reproductive Medicine. So the next question here is for male factor, 0% normal morphology and low motility, besides performing a semen analysis and a physical exam, what other tests can be done to find the root cause? Well, so I sort of alluded to that at the beginning. It's very important that men have a detailed evaluation of their medical and reproductive history, exposure to toxins, heat, chemical, radiation. We know that chemotherapy and radiation can definitely affect sperm production, especially at certain phases of sperm production, resulting in abnormally shaped sperm. So that's important. Endocrine labs is part of the evaluation. Not so much because endocrine labs will really give you insight as to why the morphology is low, but more because, again, it's just part of the male evaluation. But again, these couples can consider IUI, but oftentimes when it's at 0, we recommend moving to IVF or ICSI specifically. All right. So the next question here is, can exercises correct sperm morphology and male infertility? I wish I could tell you there was a specific exercise that could improve sperm morphology. I think the jury's out on that. And in terms of the semen parameters, I go back to what I said before, the healthier you are as a gentleman, the more that may optimize your sperm production and the quality of the sperm production. But I think there are habits that can be, negative habits that can be avoided that certainly are deleterious, like smoking and other things. Are lubricants okay? Yes, there are rare lubricants that are okay. A lot of the lubricants historically may contain glycerin, parabens, or spermicidal agents, nonoxynol, which really are pretty deleterious and toxic to sperm. So that could really obscure the interpretation of a semen analysis. So oftentimes we'll see couples using pre-seed, which is a good one. But you have to be careful about lubricants because a lot of them do impact the sperm count and the motility of the sperm. All right. Question on vasectomy reversal and timing and success rates. So a little bit about that. So probably about 500,000 vasectomies are performed every year in the United States. I know vasectomies are performed a lot in Canada, the US, parts of Europe, and around the world. But approximately 5 to 6% of men who have had a vasectomy choose to have more children in future, either with their same partner or a new partner. So a lot of these couples come to see me to sort of discuss options, because one option is to say, okay, you've had a vasectomy. Well, it's still like a car with gas in a blocked highway. So you can bypass the blockage and go directly to the factory and extract sperm directly from the epididymis or the testicle. And that's typically an office procedure. It usually doesn't take more than about 30 minutes, done under local, much like the original vasectomy. And either percutaneous using a needle, or my preference, doing a small open incision, minimally invasive, to go in and extract some fluid. That sperm can be extracted, put into a sperm wash media, taken to the IVF lab. The lab analyzes it. They freeze the sperm, and then that sperm can be used any point thereafter for IVF, the next day or a year later, because the labs do a tremendous job with freezing the sperm and maintaining the quality of it. But obviously, most couples want to pursue quickly. And there are factors that are considered for just doing a sperm retrieval rather than doing a full reversal. It depends on how many children are desired. It depends on whether or not additional genetic screening needs to be done, like PGT, to check the embryos for any genetic anomalies. Sometimes there's oftentimes a coexisting female factor, depending on age or blockages of the tubes, fallopian tubes, as I mentioned before, scarring, and other things, where even if we considered a reversal, it really is not the best path to a successful pregnancy. Now, on the flip side, we know that for the right man and the right couple, a vasectomy reversal is a very successful procedure. And timing from the vasectomy to the time of the reversal does play a role, but not quite as concrete as we used to think. We used to say 10 years and that's it. But the reality is that it really depends on a lot of factors, including the skill of the surgeon, if the surgeon is really trained in microsurgery and is able to do more complex reconstructions rather than a vas-to-vas connection. Sometimes a man needs to have what's called a vas to epididymis reconnection. That's a vasoepididymostomy. So it's a specialized reconstruction that's done if there's more scarring. And this allows couples to conceive naturally. Now, granted, they can usually resume sexual activity after about a month, but they need to do a semen analysis every 3 months for up to a year and potentially up to 18 months. So for the majority of men, we're able to see sperm in the ejaculate anywhere from as high as the high 90s, let's say if it's only a few years post-vasectomy, up to, low 90s or high 80s. My record successfully was 23 years, but obviously most of the men that we see post vasectomy are usually fall between the 5 to 10 year group. I guess at the end of the day, the age or duration since the vasectomy is less relevant than really how things look intraoperatively. Some men have a lot of scar formation, other men do not. But I always like to offer couples to do a simultaneous sperm retrieval with the reversal in the unlikely event that the reversal is not successful and it blocks off. Or it even allows couples to pursue IVF soon after the procedure, and yet they can still add to the success rate by trying to conceive naturally. So it's a bit of a win-win. But again, it's a detailed conversation away a bunch of different factors. And then, of course, when you look at the success of vasectomy reversal, you can talk in terms of sperm showing up in the ejaculate. But at the end of the day, I say to couples, well, your goal is a pregnancy, not sperm in the ejaculate. So pregnancy rates are less than the patency rates of sperm in the ejaculate. So that can vary as well. So it's important to have that conversation. So another question was asked about advancing paternal age. A lot has been discussed and reviewed in terms of advancing maternal age and impact on fertility. And we do know that there are higher rates of genetic conditions in women of advancing maternal ages. Typically, we talk in terms of Down syndrome and miscarriages. There is increasing data to indicate that advancing paternal age may play a role. There may be an association with increased genetic disorders, including autistic spectral disorders, schizophrenia, and various other syndromes, Apert syndrome, Cruzon, and a few others. So something to take into consideration, but I think it's more of a spectrum for advancing maternal or advancing paternal age, I should mention. All right. So those are the initial questions here. And I'm just looking here. Okay, so okay, so a question that came up here is from Amy. Thank you, Amy. Can you discuss the relevance of elevated prolactin in the male and how a prolactinoma may impact fertility? So elevated prolactin is oftentimes identified in women, but we oftentimes see it in male as well. So when we do an endocrine panel or hormone evaluation in men, I routinely will check a prolactin. And prolactin is a pituitary hormone that's also involved in the regulation of testosterone. So men who have an elevated prolactin oftentimes have a low testosterone, and that low testosterone can impact sperm production, and it can also impact their quality of life, their energy, their libido, their drive, their secondary sex characteristics, their sexual performance. And so when the prolactin is elevated, that suggests a possible adenoma or growth on the pituitary gland, which is almost always of benign nature, but can be disruptive to the whole hormonal axis. So for these men, when we identify an elevated prolactin, we get an MRI of the pituitary, and oftentimes we'll see a little growth in that area. And these men can be treated with agents that lower, medications that lower the prolactin level, called bromocriptine or cabergoline, which are oftentimes used in women. And that often is remarkably successful at lowering the prolactin level. And as a result, we see the prolactin level going down and the testosterone level going up. And with that, oftentimes there's an improvement in semen parameters. Rarely these men who have elevated prolactin also have clinical symptoms. They may have headaches or blurry vision or changes in their sense of smell, or sometimes they actually develop enlargement of the breast tissue, what we call gynecomastia. So that's part of the physical examination as well. Couple of questions here. ICSI for isolated teratospermia. Yeah, I mentioned before about ICSI, and it is reasonable to use ICSI for isolated, severely diminished morphology. There is a rare condition called globo-ozoospermia, where the heads of the sperm are really rounded and severely misshapen, and they can't even physically penetrate the egg. So ICSI is used, or something called IV maturation. Next question here. Improving sperm morphology. We talked about that. Can men still produce sperm with low testosterone? The answer is yes. You know, the range for testosterone is pretty wide. Depending on the lab that you look at, it can range anywhere from about 250 all the way up to about 1,000. But it really depends on how efficiently the body is able to utilize the testosterone. We know that the sperm producing cells need to be bathed in high concentrations of testosterone. So if the testosterone level is very low, you know, let's say less than 250 or less than 300, then oftentimes we'll place them on a medication like Clomid. And Clomid is a fertility drug that's oftentimes used in women to induce ovulation, but it helps to stimulate testosterone production within the testicle, and that can help to improve semen parameters in some men. And with that, another question here, is it dangerous for a man to consistently have low testosterone? Well, not necessarily dangerous, although, you know, having low testosterone is associated with clinical signs and symptoms. As I mentioned before, a lot of men can have diminished energy, libido, vitality, drive, and sexual performance. A lot of men develop depression, anxiety, irritability type symptoms, so it really impacts their quality of life. And beyond that, having low testosterone actually can be associated with low bone mineral density. So men can develop osteoporosis, not something that affects, you know, little old ladies. It can affect men as well. Sometimes men can have anemia because testosterone is also part or important for red blood cell production. Next one here is, what is my opinion on taking Theralogix motility? So, you know, I'm in favor of men taking multivitamins. I think that, you know, the data on multivitamins is a bit back and forth. It's not entirely clear. But we know that generally these nutraceuticals are safe, and the rationale is that they reduce inflammation in the semen. They function primarily as antioxidants, vitamin C, vitamin D, zinc, selenium, and oftentimes we'll add in coenzyme Q10. So I think they're generally safe, and I think that they may be beneficial. So I personally have a low threshold for recommending it. Obviously, a lot of men are pursuing a healthy diet and lifestyle, but I think it's worthwhile. Let's see here. What would cause you not to recommend an MRI for an elevated prolactin? If, for example, if the prolactin goes down on a subsequent test, yes. Oftentimes the prolactin is sort of mildly elevated, and we'll repeat it, oftentimes fasting, and it normalizes. Then I don't worry about it. Prolactin generally, depending on the upper end of the threshold, goes to about 18 or 20. So if it's kind of hovering around there, that typically does not concern me, that there really is a true prolactinoma. So ones that are really, you know, double the upper end of the threshold, and certainly if they're symptomatic, we'll check it, especially if I see it coexisting with a low testosterone. If the testosterone level is normal, prolactin just borderline elevated, I typically won't order an MRI unless there's a strong indication to do so. Question here. Older men in their late 40s with a high testosterone, 200 million sperm count, what would you recommend as far as additional testing for recurrent implantation failure? So this seems to me that a gentleman that has a normal hormone panel, assuming he doesn't have high testosterone because he's taking exogenous testosterone because the sperm production is really stellar. In this kind of situation, if there's been unsuccessful IVF attempts, typically 2 or more, or recurrent pregnancy loss, then we typically will order sperm DNA fragmentation test and a karyotype. Sperm DNA fragmentation test is often ordered, but a lot of the couples are already at the IVF or ICSI stage. I think that the sperm DNA test is helpful for couples who are kind of a little earlier in their journey and are trying to decide between IUI or IVF. But I'll oftentimes get a karyotype, which is a chromosomal test to look at the full chromosomal complement. And then here, I'm not sure if I heard the answer on Avodart or finasteride. So Avodart or finasteride are used for men with enlarged prostate with the idea that it helps to shrink the prostate. And it's also used in hair loss prevention. And a lot of young men are taking it. It blocks the conversion of testosterone to dihydrotestosterone. And, a lot of men who take it obviously find it very beneficial to their quality of life and preventing hair loss. But in a fair number of men, not all men, it can impact their semen parameters. Oftentimes we see a reduction in semen volume or decreased motility. And so as a general rule, I tell men to avoid those medications during fertility pursuit. And quite honestly, some men choose not to because they just don't want to trade it out. But a lot do. And so my recommendation generally is to avoid them during fertility pursuit. Next question here is, would you consider sperm DNA fragmentation in couples whose embryos from IVF that are high grade and euploid that failed to implant more than 3 times? Yeah, as I mentioned before, I would. What is the impact of Avodart on sperm fertility? I think we just went over that. And is Zymot effective in reducing selection of poor quality sperm? I think it's a reasonable test to do that. And I think that's being used more and more. Other things here, for situations when there's no sperm present at all, are there any technological advancements in progress for artificially replicating sperm based on the male's DNA? The answer is not at this time. I wish I could tell you, how far away is something like that. I think what is an active area right now is men who have azoospermia and are contemplating undergoing a microtesting to see if there's sperm that can be obtained for IVF. And as I mentioned before, we find sperm in about 50 to 60% of men, but it's obviously very challenging and difficult for men, for couples who undergo a microtesting and there's no sperm found. So I think a lot of the emphasis right now is trying to determine further tests that might help determine which of those men who have non-obstructive azoospermia may be a candidate for a successful microtesting and hopefully spare men from undergoing unnecessary procedure because there is a low, if not impossible, chance of finding sperm. So, those are the questions there. All right, well, we went over that one. All right, well, I think that's really all the questions here. There's here. Is there any evidence that an MTFHR gene mutation can impact sperm morphology? So that's a bit of a mouthful. That's basically MTHFR is basically a key regulatory enzyme in folate and homocysteine metabolism. And there's increasing, research on that. I think that we still need to gather more information on that before that question can really be answered. So I think time will tell, and hopefully we'll know more in the future. And then last question here, for situations when there's no sperm present at all, are there any technological advances in progress for artificially replicating sperm on the male's DNA? How far is something like that? Well, that is being looked at this stage. Again, I couldn't tell you, how far away that is, but the future is exciting. The research is happening at breakneck speed, so stay tuned. All right, so I think that we've basically reached the time limit here. And so I wanted to thank you all very, very much for turning out tonight. These questions were really great questions. Please feel free to reach out anytime, and myself, my team, will get back to you as soon as we can. Our website is bostonurology.com. Easy to find, easy to reach. So I wish you all the very best in your fertility journey, and have a great night.